And welcome to today. We're going back to basics, talking about knee osteoarthritis. And I'm sure in any profession, this is something you'll see on a weekly basis. So we're going to talk about what is the current evidence, where our evidence support service has helped us obtain that evidence. And then we'll go through kind of management plan and what it means for primary care. Now, we're very fortunate today. We've got the wonderful John Drummond, who works in the South in the MSK interface. So are you right to introduce yourself?
Hi everyone. So yeah, a bit of a last minute appearance. I'm not sure special guest is required, but thank you, Desi. Appreciate that. So yeah, I'm an APP with Connect Health. Had about 10 years experience, 11 years experience in MSK. Currently running a project in South Notts on the knee OA pathway. So kind of got a vested interest in it. Happy to do some collaboration with Desi and the team.
Brilliant. And today you've got three of us. You've got Laura, John and myself, and we'll chip in. And please, as always, either unmute yourself, write in the question box. We want to make it as interactive as possible. So as always, this is meant to be a peer review space. So please respect each other, contribute as much as you like. And obviously, if there are any other comments or feedback at the end, there will be a survey. So we want to learn of how we can actually make these beneficial for you in your time in practice. As always, you've got Laura and myself as the ARRS AHP ambassadors. Please email us if there are any other questions or anything else you want from us. And today, so we're going to go over the literature of management of assessment and management of knee osteoarthritis, what that means for primary care, but then also having a look at the Nottinghamshire radiology, but also now that we've got John, the referral pathways. As I said, we're going back to the real basics. So this should not be news to anyone. So osteoarthritis, and I'll say OA from now on, is the most common chronic pathology that causes patients to come in with pain, issues with their activities of daily living. They use more of the healthcare service, and it's quite a high socioeconomic cost. Hip and knee being the biggest contributors towards disability. And given our aging population, but also obesity, that the prevalence is getting higher, but also at a younger age. So we'll go through a little bit more on risk factors, and about radiology, that there's not always, the radiology doesn't always relate to kind of the symptoms or the pain itself. And we'll go into that a little bit more. So we are going very back to basics. So what is knee osteoarthritis, other than a big part of our diaries? So we know that the articular cartilage is made up of type 2 collagen, proteoglycans, chondrocytes and water. So a normal cartilage, it has an equilibrium. So the different components, they all work in balance, and that's how we have our healthy knee. So any degradation of the cartilage is matched at the same time with synthesis, and that's when we have our happy knees. So if a certain degradative enzyme is overexpressed, that equilibrium gets changed, and that's where we have a loss of collagen and proteoglycans, and that in those early stages of osteoarthritis, the chondrocytes start to secrete a tissue inhibitor, and the body then attempts to increase that synthesis of proteoglycans to match that degradative process. However, because of the mismatch, that reparative phase is not enough. And then that's why we start to get a breakdown or kind of that erosion of that cartilage, leading to our problems. So knee OA is very closely related to aging, but it's also important to note that it's not just aging that's the problem, but also differences in the cartilage from other factors. I want to go into other risk factors that might contribute to this process. So who does it affect? So it's the most knee is the most common. Oh, is there anything there, John? Otherwise, please just jump up.
Just in the background.
Yeah, so knee osteoarthritis is more common in females than males. But as I said, the prevalence is increasing as our life expectancy is getting higher, but also as obesity rates are also increasing, affecting about 6% of the adult population. So by the age of 60, approximately 15% of women and 10% of men will have a symptomatic osteoarthritic knee, and then it goes over 40% in over 70-year-olds. The risk factors, so things that we can have an influence, there is an influence, is if they've had any damage, so be it previous meniscal injury or surgery, ACL, previous fractures to the area, so almost that post-traumatic osteoarthritis. Occupation can have an influence, people's strength endurance, BMI, we've talked about, or weight, and just general health, so looking more at metabolic conditions. The things that we can't control, so obviously gender, age, genetics, and race. Assessments, again, teaching people to suck eggs. So your subjective is probably your most powerful part of your assessment. So that it's that gradual onset. There was no specific mechanism of injury. It's worse on activity. We do get kind of morning stiffness, but that resolves quickly. So we're ruling out that inflammatory aspect. There is normally stiffness and swelling that eases with rest. When we look at people as soon as they start walking into a room. So what is their gait like? What is their standing, lying, stance, any deformities? Having a look at the actual knee joint itself, having a look at the muscles and any atrophy, any swelling. Obviously, you're ruling out your other pathologies. And then obviously having a look if there's any instability to the area or any look of it just from them walking into your room. The basics of range of movement, basics of palpation, ruling out that there aren't any other structural soft tissue injuries, be it like your ligament laxity or your meniscal, but that's where, back to my subjective, that will tell me a little bit more. So when we're thinking about meniscal injuries, consider the person's age and actually what has happened in the meantime. And then I've talked about testing. So we've got the patella grind test or Clark's test if we're looking at more that patellofemoral pain, but it's a really non-specific test. It's not gold standard. There's not even kind of sensitivity, specificity on this test. So it's just take it with a pinch of salt in that wider picture. And that's where I think subjective is probably your more powerful part of your assessment. Anything else to add, Laura or John, on what you assess? And we're talking in the primary care environment as well. John?
Just to remind people that meniscal testing, like McMurray's, it isn't recommended in NICE. We still have quite a few referrals where somebody's kind of scooping around an already kind of grotty knee in a 70-year-old, 80-year-old. It's not necessary, and it's not useful for us at the point of triage or diagnostically. So just a reminder, it was based on a systematic review by Ben Smith in 2015, and then that was implemented into NICE. So yeah, to just reduce the use of that. It's much more important subjectively what the person, if they're having mechanical symptoms. That's all. Just wanted to add that.
And one of the reasons I didn't even go into meniscal testing, because actually then we're probably not thinking osteoarthritic being the main concern. So now looking at the whole picture, and this is probably where primary care, that's the big part for us. So back to the basics. So we've got kind of primary knee osteoarthritis. So that's where we have that articular cartilage degeneration, but without a known reason. The secondary OA is basically there's been a reason. So is it that they've had previous trauma, previous surgery, etc., etc. However, so things that we need to look at as well is that whole picture. So osteoarthritic pain can be influenced by lots of different things, be it physiological, psychological. So is the patient depressed? Are they catastrophizing? Is it they've looked at other people in terms of having knee pain, and that's where they're catastrophizing that pain because of what they've seen from someone else? Have a look at the demographic features, but also other comorbidities. So that's why I think it's only about 15% of people with OA actually are symptomatic. So that's where the image itself isn't enough. We need that whole picture. Having a look at, so we've got the different types of pain. Again, I'm not teaching people to suck eggs. So we've got the nociceptive pain, which is from the degradation, the inflammation. We have neuropathic pain if there's anything related to the nerve itself. But then we have nociplastic pain, so more that sensitization. So be it when you touch a knee in any certain area, and that's where they're feeling pain, but it might be out of proportion to, say, the image. The image might say there's mild joint space changes, but actually they're in high level of pain, persistent pain, unable to do their day-to-day. And that's where these kind of people have that poor surgical prognosis and are less responsive to analgesics. So it's having a look at that bigger picture, probably, you know, putting them forward for surgery or putting them to secondary care. That might not be the most appropriate. Is it that we need to have a look at the other comorbidity management, be it the hypertension, the diabetes, their weight? Is it maybe pain team that they need to have a look at more that sensitization side of things? So in primary care, look a little bit at the bigger picture, not just that OA knee pain. So let's get in the chat box. What else could it be? So if we're not looking at OA knee, what other things could we rule out? So we've got pain at the knee. Sarcoma, oh, we're going straight for the big ones. Oh, gout, yeah. I assume that's patellofemoral pain syndrome. Hip referred, like it. DVT, yep. Tendinopathy, good. I think we've hit the main ones. So we're hitting it. Other types of arthritis, be it inflammatory, with gout, other soft tissues, so tendinopathy, bursitis, other actual injuries, so meniscal ligament tears, referred pain. So is it from another joint or is it radicular pain? Are there other pathologies going on? So as I said, is it referred pain or are there fractures, be it, so it's not on this list, but if it is necrosis, so they are the main ones, but good. That's where in primary care, think laterally and outside of the box. So this is poll time. Right. We've got someone coming in with knee pain. That is it. Are we imaging? And if so, what? I'll quickly do a poll. So you are in the
Sorry, Desi, I was just trying to do it for you, but I'm not as technically capable as you.
Right, I've lost my poll. All right, right in the chat for this one. I will get the poll ready for the next one. We've got options of X-ray, ultrasound, MRI, nothing. Nope, right here. Oh, you get a poll now. X-ray, ultrasound, MRI, nothing. You can tick multiple if you feel like you need to do a lot. There's no history. If person has just come in, they've got progressive onset knee pain, no trauma, struggling to get up and down the stairs. Can we all see that? I'll just check, is the poll in the group? I've got, oh yeah, sorry, yeah, people are, oh, nothings are outweighing. So it depends on age, symptoms and history. Now my next poll. Virtual hand up, are you an injector? Or have access to an injector? And when I say injector, steroid injections. There we go, hands are flying up. So yes. Oh, again, my polls do not want to work today. Would you do an X-ray before you do a steroid injection? Just write in the chat, yes or no. My polls aren't playing with me today. You can even do thumbs up. So X-ray before. No, so majority no, a couple yeses. If you're happy to explain what would be your indication to do an X-ray before an injection. So investigation. So X-ray is your main for osteoarthritic knee pain. So if we've ruled out that there's nothing else nasty going on and that's more your subjective history, so we're not worried about anything inflammatory, radicular, if over the age of, so NICE guideline says over the age of 45 with activity related pain and morning stiffness that's less than 30 minutes, that's where there's not an indication to do an X-ray of a knee, because you're going more off the symptoms. An X-ray won't change much. As I said before, the X-ray changes doesn't always relate to the level of pain. So that is, so ultrasound not indicated. MRI is only really if you're ruling out another pathology, but it's not to diagnose osteoarthritis. So the Nottinghamshire guidelines, I know this is very small. Your X-ray, again, is if you're ruling out a fracture, so if there's been a trauma, again, if they've not ended up in an urgent care or an A&E, that's where you would do an, like as per like an Ottawa rule, that's where you would do an X-ray knee. But if it's a suspected OA knee over the age of 45, it's not deemed necessary. At this stage, they've just appeared for the first time with their progressive onset knee. So you can consider it if you're being considered for a surgical intervention, but I'm going to hand over to John in a little bit later to discuss that, of when it's actually going to help that management. But ultrasound and MRI. Oh, what was that?
It's okay, I'm just responding in the chat, Desi, sorry.
Oh, sorry, thank you. I can see the chat going off. So these are the X-ray guidelines again, and it's the difference between an MSK specialist, so that might be your FC, your first contact practitioner physio, or it will be your interface service. So that's where it depends who you've got in your surgeries of who can and can't order certain images. So for example, like a painful prosthesis, that's where an X-ray is indicated to determine if it's going to need onward ortho referral. Again, ultrasound, MRI not indicated. Pain without trauma, again, sending more to an MSK specialist, be it your FCP or interface service. And then it's your degenerative meniscal tear. Again, X-ray is not indicated. MRI, but only in a specialist setting, because it will determine if it's going to change the management, but that wouldn't be something that we would deal with in primary care. And then knee pain with locking or meniscal symptoms. So if it's acute, so I've played football, twisted my knee, and now I'm getting locking, straight to A&E or straight to urgent care, acute knee via fracture clinic. That's where they will image, and that's what they've requested anyway, is that they do the imaging and not wait for primary care for an acute meniscal. John, do you want to jump in if there's anything else when I just talked about the degenerative of what you might image in secondary care?
Yeah, I suppose, so we kind of categorize it as you've said, to traumatic or non-traumatic, and then are they young and active? So that's much more likely to need acute knee clinic. Are they kind of middle grey area? And that's the more difficult cohort. So somebody who's over 65 or perhaps a little bit younger but inactive, or a little bit older but very active, we probably wouldn't be thinking about MRIing. We probably lean more towards X-ray, and if there's established osteoarthritis, that probably top trumps the meniscus type problems, and we treat it as non-traumatic knee pain. Obviously, if there's been a trauma, and especially if they're younger, then they'll need acute knee clinic or potentially MSK interface to organise things like MR routinely.
Thank you. So first line treatment. So we're back to Mrs. Bloggs, who's come in. She's making 55 years old. So no trauma to her knee, never had trauma in the past, but now struggling on stairs, pain when she's active, but eases when she sits back down again. So first line treatment, and this is like NICE guidelines, is looking at exercise. So your general strength, mobility, general fitness, and that's where it can be done via your first contact practitioner, or they might refer on to your interface for the more rehab side of things. NICE guidelines says about thermotherapy, so using heat and cold. Manipulation and stretching, so that's where we probably in NHS services advise more self massage, self-help techniques, whereas say in a private they might want to get kind of manual therapy treatments, but that's not a NHS service. Electrotherapy to help with pain, but again that's where your clinician can advise on it, but that's where it's not something that we obviously hand out or distribute. We can talk about footwear, so obviously it's not always just the knee itself, it's having a look at the whole chain. So is it about those education topics, and that's probably a big thing that's not on the guidelines, but just general education on what is OA knee. That's where there's a really good link, if John you don't mind putting it in the chat, so the Keel, it's like a 4-minute link that you can send to patients, so it is that education input and you don't have to spend your time in primary care, but a really helpful resource to help people understand kind of what are the basics. Obviously we can have a look at assistive devices, so be it walking sticks, if you have more your elderly patient or it's causing functional limitations, consider reablement. So your community services, so if they do need aids, so in the south we are able to refer to consider some aids, but they're your basic sticks or crutches. But if there's any issues in the home, so maybe you're more elderly patient, are you struggling to get on and off the toilet, in and out the house, those kind of things, that's where I might put a referral to community services as well. And then don't routinely offer braces, so kind of like medial offload brace we wouldn't do in primary care. I'm not sure if John you do it in secondary care.
No, so we consider it. So if somebody's got radiographically single compartment OA and we think that they're that kind of middle age bracket where they're probably not quite a surgical target for a unicompartmental, we would have to refer to ortho to consider more advanced bracing. I tend to slightly go against NICE on this, just in terms of I think that if people have already got a brace or are thinking about it, it's generally low cost, low risk, and apart from getting a bit of a sweaty knee, it's unlikely to cause a significant harm. So I sometimes consider it, and I certainly wouldn't tell people not to wear it. It's a bit different to when people have kind of spinal braces, but obviously if it's really limiting that person, they're really afraid of moving, and they have to have a brace, then it can be counterproductive.
And I'm going to hit on weight loss a little bit more. So what can we do in primary care? So optimizing those other comorbidities. So the research says that the amount of weight loss can yield more benefits. So even 1% of weight loss was associated with 2% reduced risk of having a knee replacement, and then 3% reduce the risk of hip replacement. And one thing I have learned, and that's where now I'm changing my practice, is actually documenting BMI through that kind of pathway. So either making sure that in primary care, have they got an up to date, because then that can help that onward referral when it goes to secondary care. So next poll. So any prescribers, or if you're a non-prescriber, what would you consider recommending or speaking to your prescriber about? So let me get my polls back up. So we're back to pain is limiting the ability to do rehab. New poll. So they're not in a very good order. Okay. Just tell me when it's, someone tell me if it's gone in. And if other, write it in the chat. I've forgotten neuropathic. That should have been one of my options. Codeine, yep. That was on my list. I did not type in my poll. Good, so very much topical, anti-inflammatory, or paracetamol. Other, I assume that's codeine because I forgot it on my list. NICE guidelines. So this is where it gets a little bit different depending which guidelines you look at. So similar to the frozen shoulder. So initially topical pain relief, and then looking more at the non-pharmacological process. So weight loss obviously comes up. It says about cognitive behavior therapy, rehab and education. In NICE guidelines, it said at first line to consider steroid joint injection, but that's where I think that's probably where it's out of place, but it's put it as one of its first line. So it says the second line, paracetamol and topical plus the above. Third line is then add anti-inflammatories. The BMJ then said about hyaluronic acid injections, that is not a NICE guideline or NHS service, and I'll talk about that a little bit more in injections. And then lastly, it's going more opioid or consider your neuropathic like your duloxetine. So that's as per NICE guidelines. But back to basics is having a look more at the rehab, and that's what alongside it always goes on alongside more the physical or the first line treatments. So injections, so back to our injectors in the room. Do not offer hyaluronic injections in the NHS service as per NICE guidelines. However, we know that it's completed in private practices. So injections, consider it when other pharmacological treatments are not effective or not suitable. So we know from other comorbidities or how much analgesia they might be using, but it's making sure the person knows that it's only a short-term pain relief, so kind of 2 to 10 weeks. As an injector, I try to explain it as the window of opportunity to then do the adjunct treatments. And that's where, and I commonly try refer to the MSK interface to get the most out of having that pain relief opportunity. Laura, do you do anything different as an injector yourself?
No, I do the same, and I sell it as an opportunity to get more active, to lose a bit of weight. I tend to omit the information about the 2 to 10 weeks because I think that it isn't helpful for patients to know that it can have such a short-term effect. So I generally would say some people have 6 to 12 months pain relief. You know, hopefully you'll be in that bracket, because just in terms of kind of placebo and expectations, I think personally it's not helpful for patients to know that the results are so short term. Be interesting to know whether other people share that information with their patients or not.
And this is where I was having a good conversation with John. It's where it's best placed to have the injection. So I know we do it quite commonly. It happens quite commonly in primary care, but within the pathway. So John, if I can get you to jump in, so about injections within your service.
Yeah, of course. So I think it's difficult because things have changed. Whereas before it might have been a more linear pathway that people traditionally saw a medic, then they might be referred to a physio saw them for a bit, then they might go to an extended scope practitioner, then they go on to ortho, or it was fairly linear. We're now kind of having people trained up more in different parts of the pathway, and it's obviously quite front loaded with FCPs. So since we've seen FCPs begin injecting, we're kind of not seeing that same stepped care approach where it's varied between who you see as to where you get an injection amongst the pathway now. So some people are ending up with an injection before they've really even entered rehab services, which is a bit unusual. And then some people within rehab services can also inject. So then we're seeing a few injections kind of there. And then also we're seeing them in tier 2 as well. So whereas before, you'd have a few GPs maybe that could do it, we are seeing it in different places on the pathway. I think from my personal opinion, if it's given in primary care, it really needs to be those kind of rescue type ones where somebody's really struggling, they've got a swollen knee, they can't engage with normal life. If we're thinking that this is to manage their more kind of regular type of thing, my thoughts are they probably need to be more comprehensively managed within an MSK service. But that's just my thoughts.
And this is probably where it brings out the big debate about, and the hard part is when people come in and it's that they can't engage with anything else. So I will probably hand over to you now, John. So it's about making the referral for ortho consideration. So how can we help in primary care to put patients in the best position when they do enter?
Yeah, so I am looking at this in a little bit more detail in a project that I'm doing, which I'll share with NATH and the team at a later date. The referral criteria via GIFT and NICE is quite clear, and I think that it's worth bearing in mind that although as a triager we often have access to System 1 notes, if it's not on your letter, then it doesn't go on to orthopedics, and we need to make sure that orthopedics have got kind of comprehensive information. Probably what we're finding is that x-rays are being done still kind of earlier on in the pathway, and I think that that's leading to then kind of duplication and also expectation setting for patients. So I think it's absolutely fair enough if somebody's clearly trialed, 6 months of rehab last year, they were managing okay, but it's got worse, they need a new x-ray, and that's organised in primary care, and then they come through the triage service. That makes total sense. But if we can make sure that it's very clear that this person is for elective orthopedic pathway, they've trialed this, these are their symptoms, this is their recent x-ray, you've had a shared decision-making conversation, and they've opted for elective ortho, then that makes it kind of, we can confidently triage that then straight to orthopedics. Whereas at the moment, due to kind of incomplete information, we're then having to repeat an examination, and it's often then duplication for the patient, it's wasted time for us. But yeah, happy to share kind of best practice, gold standard kind of letters at a later date when I've planned that a little bit more.
And this is where GPs, ACPs, AMPs, it's making sure that the patients are optimised if you're going to consider for surgery. So other comorbidities, you don't want to put them forward to then say their AF, their diabetes is not well managed, so they're not going to be a suitable candidate. Having a look at that weight loss side of things. So again, my learning recently is making sure we're documenting BMI through the pathway, especially in primary care. We see them at lots of opportunities. Sorry, John?
So I was just going to say, so this was following a meeting from Benjamin Block at NUH, and he was quite keen for BMI to be documented a bit more. So we don't actually record it routinely. Part of the reason for that, in a silly way, we don't actually have the equipment to measure somebody's height and weight. So let alone the time, but simply we just don't have some scales to say, can you jump on here? We need to get an accurate recent weight and height just routinely. But I can imagine that the orthopedic end are probably wondering that we've got auxiliary staff or kind of timing clinic that people are kind of clerked in and they can go through those routine measurements, but simply we don't have that. And the data that sometimes comes through is it's a BMI, but it's from 2012. So was that when they were really active? And now since they've had arthritis to the knee, it's deteriorated. So is it accurate or not? But it does influence their triage decisions.
And then we're going to that surgical option. So in primary care, this is where we don't have an influence on these decisions. But it's obviously when it gets to orthopedic, they'll decide if they're looking at joint preserving surgery or joint replacement, be it unicompartmental or a full total knee replacement. But when, as I said, it's what can we do in primary care to put them in the best position when they end up sitting in front of orthopedics. Noting that at the minute, the research says 20% of people who've had a knee replacement report dissatisfaction. So be it that they still have persistent pain or functional limitations. And that's where I think where we can make a difference in the beginning of the journey, and put people in the best position when they do end up in the most unconservative way of treatment. So this, again, people get sent these slides. I know this is very small. It's kind of a little bit of a journey, a flow chart, just to help with some of that decision making, but it's everything that we've discussed today. And then finally, so we're near the end. So if there are any other questions that you feel like we haven't covered, or anything specific for John in his MSK interface hat, or because he's doing a lot more research into the Knee OA pathway, then please put it in the chat. But in primary care, it's to consider. So ideally, if someone's coming in with knee pain, if you've got an FCP MSK, book them straight in with them. That's where having a look at the exercise, the strength, advice on any walking aids, sending out these resources, and it's all in the chat as well that John has kindly put in. Having that weight loss discussion where indicated, and looking at the other comorbidities, making sure that people are going to be in that best position, or it's saying, and it's having the difficult conversations about weight loss, how much of an impact that can make on load bearing joints. And that could be anyone from GPs, ACPs, nursing practitioners, and your FCP colleagues. I've not put in paramedics, but again, they're very well placed to have that education conversation. In primary care, make sure we're ruling out other pathologies, so that it's not an inflammatory, and again, that subjective history is where it's really important. So are they getting night pain? Is it that there are other joints that are involved? Is it, again, red hot swollen? We're looking more at a gout related. Does it actually travel up the leg? So we need to have a look higher up the chain. So that's where it's really important that we're not just saying, oh, it must be OA knee pain because it's a common pathology. Pain relief. So pain relief is always alongside the more physical and education treatments. So as per NICE guidelines, it's making sure we go topical before we go for oral, and then escalate up and consider the sensitization factor. This is where I've put it on the list lower down compared to what NICE guidelines is saying being first line medication. That's where injections should come in once we've tried the above, and then it's to help complete, or that window of opportunity to ensure that optimize, or again, it's referring onto that interface. So it's that linear pathway that is not all happening in primary care. And then lastly, as per what John has said, it's that referring onto that secondary care, that MSK interface, to consider if a surgical opinion is required, given that they've tried analgesia, had a good spell of rehabilitation, injections have been ineffective or they're unable to, and then that's where they might consider surgery. Anything else, Laura or John, from what that pathway? No. So, and just to be aware, you've obviously got a really good resource as the shared decision tool. So that's where you can print it out for your patients, and it says, if I do nothing, this is what will happen. If I do this, if I do that. So we've got a couple of common pathologies being hip and knee OA. I think it's Dupuytren's and carpal tunnel. They're the main ones that you get a really nice document. So even if it's that education, giving it to the patient so they can start to think about what they want to do moving forward. Again, when you get the slides, you'll get the link as well. And then you get many references when you get your slides. So we'll go over questions in a second, but just so you know, we've got some more events coming up. So these are all links for you. So on Eventbrite, you'll see we've got 18 coming up until the end of the year. We're doing the effective use of anti-inflammatories in clinical practice, more for non-medical prescribers. So it's having a look at that wider picture. If someone's coming in talking about over-the-counter, like ibuprofen use, what other questions you might need to ask. We're having the podiatry service come in a couple of weeks to talk about making an appropriate referral to them and what pathologies they can really make an impact on. And then another evidence-based discussion on sciatica and radicular pain. And that's where I think we've got the spinal service, the NAZU, coming in to support that. So please come join, bring your questions. All of these recordings end up on YouTube, so you can watch back at a later date. Everything goes in the Grow Knots app, and all the clinical and non-clinical education sessions will go on there as well. And you know that you can get in touch with us.